one of the major problems with stroke is that they usually, for some reason or other, seem to occur at night while a person's asleep. And for that reason, very few people get to the emergency room in time. And even though we've had this huge push, a robust stroke center like our place, we're only seeing maybe 50 patients a month. Well, you know that there are many more strokes occurring than that. And what was absolutely astounding was during the COVID crisis, our stroke prevalence in the emergency room plummeted. So we suspect that a number of people were just staying at home with their TIAs and minor strokes. And the relevance to this is obviously for the individual, we have to start treating them with TPA within 3 hours and preferentially with intra-arterial therapies within 6 hours. If a person has had a TIA, when you see them in the emergency room, they're going to ask you, well, what's my risk for having a stroke, within the next month or within the next year, and on average. And you can see here that once a person has had a TIA or a minor stroke, the first month, their risk ratio goes up 12-1, and over a year, 4-1. And on average, the annual stroke rate for a person that's had a TIA is about 7% per year. What are the treatment modalities for stenosis? It's surgical, and within surgical, I include endovascular therapy, and I'll talk briefly about that. I was asked predominantly to speak about carotid endarterectomy, but then there's medical therapy, and medical therapy now is beyond antiplatelet therapy. It's also the statins, and that's the focus of the CREST-3 trial, is more aggressive management in patients with moderate and severe carotid occlusive disease. And we'll wait and see. I personally feel that in competent hands, the risk of doing stenting or an endarterectomy is so low that it's going to be very difficult for medical management to beat the eventual outcomes of surgical intervention. And this was shown way back in 1995 and 1998. The European trial corroborated the NASA trial, which showed that for patients with greater than 70% stenosis, there was a sharp breaking point between the advantages of surgery and medical management. There was a significant reduction in the risk for having major stroke or death in patients that were treated surgically versus medically. In the NASA trial, the reduction was 17%, reduced from 26% down to 9% in patients that were treated surgically. The benefits after 2 years, you can see, are significant, from 26 down to 9. After 5 years, in the 50 to 69% range, there is also some benefit. So patients that have either minor symptoms, TIA-like symptoms, with 50% stenosis, what we will probably do in that population is do transcranial Doppler and look and see whether they're having an increased incidence of embolic events. And that patient we would consider strongly for some either endovascular or surgical intervention. This is just a Kaplan-Meier curve, again, demonstrating the significant benefit of surgery in the 70 to 99% group, and also a significant benefit in patients with 50 to 69%. Corroborated by the European carotid trial, similar reduction from 17% down to 4.5%. So significant benefit to surgical intervention for carotid occlusive disease. And this led to the way we basically manage things now. In a patient that's symptomatic with greater than 70% stenosis is going to get a CEA or stent, depending upon their medical comorbidities. Patients with 50 to 69%, we have a debate, less than 50% with medical management. And I want to remind everybody of the ACAS, which is the asymptomatic carotid study, which showed that there was significant benefit for men with carotid stenosis. Why better in men than women, we don't understand. But it was also different in that it was the significance started at 60% stenosis. I am finding that the neurologists are less willing to allow us to operate on patients with 60% stenosis, but this was a very well-run study, and it clearly showed significant benefit. And I think that if you are working in an area where your surgical morbidity is less than 1%, and I've never lost a person with a carotid endarterectomy, so mortality I think should be virtually negligible. You can certainly make a strong argument with the neurologist that you might want to treat a patient with this degree of stenosis.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.